Welcome, everybody. Looks like everyone's starting to join. We'll get started in just a moment here. Okay, it is 2 o'clock Eastern time here on the dot. We will go ahead and get started. Welcome to today's webinar, Understanding the Primary Drivers of Loss in Long-Term Care, Managing Risk Where It Starts. Can you do the next slide? Great. Just a little bit about who we are at Care Agents. We are a liability insurance solution really focused on senior living. We do provide coverage for a number of other healthcare industry people. And, we focus on comprehensive risk management services, aggressive claims management, and we've partnered with a few technology vendors to make an impact on claims management. So we'll be talking about some of those areas today. Just a few housekeeping items. So all attendees will remain on mute throughout the presentation to ensure we can have a successful webinar. If you have any questions or comments during the hour that we're together, please feel free to add them to the Q&A feature at any time, and we will certainly try to get to those as time allows. At the conclusion of the presentation, please help us by filling out the short questionnaire that will it will pop up at the end, at the conclusion, and really that'll help us better serve you for future topics. There will be a link to the recording and the slides that will be sent out to all attendees at the conclusion of the webinar. And for anyone seeking nursing home administrator CEs, we will file your attendance with the CE credit with the NAB. And for nurses and nursing home administrators, again, wanting the CE credit, there'll be a QR code at the end where you can download your certificate. We will certainly visit that at the near the end here. And really, this webinar is for informational purposes only. This doesn't constitute any sort of legal advice. We are speaking really from a risk management perspective today. And I would like to go ahead and introduce our speaker. Monica Chadwick is the Vice President of Risk Management for Care Agents. She's a registered nurse with a Bachelor's of Science in Nursing and holds advanced certificates as a legal nurse consultant, certified, and a certified professional in healthcare risk management. Monica has over 30 years experience as a nurse and has been a legal nurse consultant for a defense law firm and has been in the insurance industry for over 15 years. So you'll see that she brings a unique blend of clinical, legal, and insurance expertise to our senior living clients and for today's webinar. So I will go ahead and pass it over to Monica to lead our discussion.
Thanks, Tony. So I appreciate all of you joining us today to talk about this important topic. And just to reiterate what Tony said, I have been a nurse for many years in the hospital setting, in home health, hospice, but I kind of took a detour into the defense law practice as a legal nurse consultant. And for many years, I worked specifically on defending senior living facilities against cases and litigation. So I very much enjoy being on the risk side of things, and so we can talk about how we can mitigate risk so hopefully you don't end up with claims and lawsuits. So let's talk about the learning objectives for the presentation today. We're going to identify the most common drivers of claims and lawsuits in senior living communities, and then we're going to differentiate key liability drivers and allegations in skilled nursing facilities and compare those to assisted living facilities and talk about what some of those differences are. And then we're also going to spend quite a bit of time talking about practical risk management strategies to mitigate exposure to claims and increase defensibility. So as we get started, I want to talk about a few of the terms we're going to use quite a bit in this presentation. So this presentation is put together by looking at actuarial data from a variety of providers, and they come out with benchmarking reports every so often. So these benchmarking reports were used to analyze both the frequency and the severity of claims. And it's important to really differentiate these two terms because the statistics look different. Frequency, of course, is going to be the number of claims per unit of exposure. And so we know that falls are consistently going to be the highest claim frequency type of loss. But then we also have severity, and it's really important to differentiate that from frequency. So severity is going to be the amount paid per claim. And so a high severity example is an elopement claim that pays out on average $285,000 per claim. And some types of claims are less frequent, but they have a higher severity, and elopement is one of those. So it's important to differentiate those two. So let's start off by looking at the top claim types for frequency of cost. And so this is across all senior living facility types. As we know, falls are going to be the most frequent at 41% of claims. Pressure injuries are second at 22%. Improper care is 18%. Failure to monitor 4%, and abuse is at 4.2%. And falls are a factor in 53% of assisted living claims versus 37.6% of skilled nursing claims. So assisted living facilities are having a much higher frequency of falls than the skilled facilities. And when we compare that to the highest severity claims, resident abuse is going to be the highest severity type of claim, paying out on average $384,000 per claim. Failure to transfer a resident to a higher level of care is second highest at $312,000 per claim. Failure to follow physician orders is third at $311,000. Medication errors come in at fourth at $306,000, and elopement at $304,000. So I just want to put this into kind of perspective about where they all look. So you notice that pressure injuries and resident falls aren't on that high severity list for the top 5, but I wanted to sort of show you where they are as far as the top 10 and how they rank. So here we've got pressure injuries coming in at 7th as far as severity, averaging $266,000 per claim, and resident falls at $239,000 per claim. So here's something that I just want you to think about for a little bit. I'm going to give you the answer here in a minute. But on average, what do you think have a higher claim severity, skilled nursing facility claims or assisted living claims? Which of these types of claims do you think pay on average a higher amount when we talk about severity? I'll give you the answer here. It's actually assisted living claims. And assisted living claims pay out on average 14.4% higher than skilled nursing claims, which I think that's really significant. And it's important to, and we can talk about some of the reasons that we think these occur. It might be from not as much documentation. There was one study that showed some staffing issues that are very prevalent in assisted living. The lack of being able to find staff might lead to that failure to identify residents that require a higher level of care. Also, assisted livings don't necessarily have the documentation standards and requirements, so we don't have as many documents to refer to as we're defending these cases. So there are quite a few things that might play into why we see this statistic. So let's take a minute to look at the top claim allegations in skilled compared to assisted living. And I think that this is really interesting that there are some variations here that we see. In skilled nursing facilities, we see that resident falls are, of course, number 1. Pressure injuries, number 2. Improper care, this is excluding falls, is 3. Failure to monitor, 4. And resident abuse is 5. Where we compare that to assisted living, falls again, number 1. Improper care, excluding falls, comes in at number 2, so it moves up a bit. Resident abuse is number 3. So compared to skilled nursing, where it's number 5, it's pretty interesting to see that resident abuse is much more frequent in the assisted living community. Pressure injuries at number 4, and elopement is number 5. So whereas it's not even a top 5 in skilled, it is going to be a top 5 in assisted living. So a few interesting statistics when we look at falls and senior living claims. So this information is based on 917 closed fall related claims. And in these fall related claims, they found that 59.5% of the falls resulted in death, 64.8% of the falls were unwitnessed, and 59.7% were involved with residents with a prior history of falls. So that kind of gives you some insight as to where those fall claims are coming from and what the outcomes are when we have those fall claims. But this is based on a pretty good data set to give us this type of information. When we talk about pressure injury claims, we know this is 22% of all claims. and these are paying out on average $266,000 on average per claim. Elopement claims, the average severity is $285,000. 45.5% of elopement claims result in death, which that is significant. So almost half the time when a resident elopes from a facility and it results in a claim, it's because the resident died as a result. 60% of people with dementia will wander at least once. So this is telling us that when they might not be wandering when they come into your facility and they're admitted, that there's a very high probability that at some point they're going to wander if they have a diagnosis of dementia. We know that memory care units have a heightened exposure risk. This is going to be because these are considered to be locked units. And so when a resident does elope from what is considered to be a locked unit, a secured unit, the family really feels that there was a deviation from what was expected and what was promised to them. So these cases are difficult to defend. And elopement claims with a death pay on average $417,000 per claim. But the other thing that we need to talk about when we're talking about elopement claims is just the reputational damage that has a significant impact on these claims. Because when we have these claims where a resident elopes and they die, it makes the news, it makes the headlines. And here are just a few examples. Just within the last couple of months, there was a situation where a 93-year-old woman with dementia wandered outside of a facility in freezing temperatures. She was found in a snowbank 3 hours later, died from hypothermia. Another case where a resident eloped 3 hours after admission. The staff saw her leave, silenced an alarm, and didn't notify anybody, and the case settled for $2 million. And here's an example of another case that the resident died after accessing a locked courtyard. They weren't noticed for nearly 2 hours, and it was part of 115 elopements in Maine in 2020 to 2022. So when you've got a big, significant number of elopements, a jury is going to be encouraged to send a message, those types of things, and make an example out of these cases. So that's why they can settle for very high awards. But just to keep in mind that elopement is not just about the money you're going to pay out on a claim, but it's going to make the headlines as well. When we talk about medication errors, this is 1.9% of total claims, but the average severity of a medication error claim is $305,000. 44% of these claims involve the wrong resident. So I think that is a very significant number to think about. So if you have facilities that you're seeing a high number of medication error reportings, go in and look to see if that is related to the number of agency staff that you're having. So if we're giving medications to the wrong resident, is it because you might have staff that aren't familiar with the resident population, or you might have a high turnover in staff? But if you do notice those things, you might need to mitigate the risk of wrong resident medication administration and figure out a way to ensure that your agency staff are providing the medications to the right residents and have a solid mechanism in place for identifying the residents. 24% of the claims involve the wrong dose. And those claims that involve the wrong dose of medication pay out on average $457,000 per claim. So when the nurse makes a mistake or the med tech makes a mistake and gives the wrong medication, that's going to be a very expensive claim. So that's why it's so important to be sure that your staff has competency with medication administration and you verify that. Because if they make a medication error with the wrong dosage, they did the math wrong, basically, it's typically what happens. It's going to be a very expensive claim to settle. Let's talk about abuse claims. So abuse has 45.7% increase in severity in skilled facility claims. And I believe that's over about a 4-year time period that they looked at that number. And it's increased 17.3% in assisted living claims. And abuse claims have increased from 2.6% of all claims to 4.6% of all claims. So abuse is one of those allegations that we're frequently seeing in litigation. It's kind of one of those, they throw it into the complaint a lot of the time because they don't really have anything to lose by throwing it in there. But we're having to defend abuse claims as well, which further complicate the defense. Another thing to talk about is just the wide gap in variations between state to state. And for those of you that operate at a national level, you're probably aware of some of this information. But I think it's so important to look at these figures because it really is pretty incredible how much variation is between claims payouts in certain states. Um, Kentucky is almost 10 times more expensive for operators than the lowest cost state, which is Texas. And costs in Kentucky have more than doubled since 2016. Loss cost used to be $828 per unit, and the average severity of claims in Kentucky was the second highest at 200,000, rising from 185,000 the previous year. So just in 1 year, it went up from 185,000 per claim to 200,000 per claim. And Kentucky has the second highest claims frequency, which is second only to California. The cost of living in California is 37% higher than Kentucky, so it really doesn't align with any type of cost of living. It really is about the litigation landscape that it is taking place in Kentucky. And we know that Florida is also a very expensive state as far as litigation, $1,325 per unit, and it's rising in frequency. Illinois, $1,100 per unit, and the highest frequency is 10 per 1,000. The lowest, and it's really interesting when you see the whole spectrum of these cost analysis, the lowest is Texas at $180 per unit. But there are other states that are equally as low or pretty much in that same ballpark. Ohio is only 300, Michigan is 425. And just to add, if there are any other states that you would like the information on, or throughout this presentation, if you see any of these numbers and you would like to know where these numbers came from and specifically cite the report, I'm going to put up my email address at the end on the very last slide, and feel free to reach out to me. So if there is any specific information, I can point you to the benchmarking report, or I can find it for you, and we can provide some other information too, because I know this is just sort of a high-level snapshot of things, but there might be some states that you're more interested in, or some of the other statistics that you might really be interested in taking back to your organizations. So let's talk about some claim trends. So senior living loss costs of claims continue to rise, and they're rising at an annual rate of 4%. So we know that this is outpacing the rate of inflation, and that's significant. For some reason, year after year, they're at this elevated rate of increase. But the severity of claims is $135,000 average per claim. And one thing about that, the severity that is interesting is this is actually down from previous years where it was up to $145,000 average per claim. Another thing to keep in mind too is the impact that COVID has had on some of these claims. So it has been interesting to look at the statistics, and sometimes things will increase and then go back down. So there are some variations across the board that may have been impacted by COVID and higher acuity residents in nursing homes and that type of thing. But loss costs have risen by 1/3 since 2016, and it's driven by offsetting dynamics in frequency and severity. But a 1/3 increase is significant. And the significance of increase in resident abuse allegations, a 45.7% increase in SNF claims, and a 17.3% increase in ALF claims. Another thing to keep in mind about this data is what they did is they took out the large losses that were over $1 million when they looked at these benchmarking reports. And the reason for this is twofold. First of all, these are insurance carriers that are looking at these losses, and typically losses are capped at $1 million for insurance coverage claims. So they took out those $1 million plus claims, but also not to skew the data so much. So if you have some of those huge multi-million-dollar verdicts, it's not going to skew your data to look like something has a greater average severity than it really does. So it kind of keeps the data set consistent. But I wanted to talk about these $1 million plus claims just so you kind of have an idea of where they come from and what type of claims we're seeing that are paying out for over $1 million. For all senior living claims, 31% of these claims are from falls, 16% are abuse. But this is an important figure that I hope you remember. 10% of these $1 million plus claims are choking claims in senior living. And we can talk about that a little bit more when we talk about risk reduction strategies. But what we're seeing in these choking claims is that it's typically a resident with a prescribed diet. They have to have pureed diet, something to that effect, something very specific because there are known choking risks. The diet orders are not followed, and they end up choking, and more often than not, they end up dying because of the choking event. So it's really important that you might not see a lot of choking claims, but when they happen, they're very expensive and typically over that $1 million figure. Long-term care, specifically, falls are 20% of just in the SNF setting. Infection is 13%. So when you think about infections in the SNF setting, it's probably a case of sepsis, might be an infected wound, that type of thing that's going to lead to litigation. And then skin and wound is 10%. So those are going to be pressure injuries. I also want to touch on the importance of timely claim resolution, and I think this really exemplifies why it is important to resolve claims as quickly as possible. So we know that 30% of claims take 5+ years to close, and this is actually 42% of total payments in senior living cases. So the claims that are coming in at 5+ years are paying out on average $244,000. And if you contrast that with the claims that resolve in less than a year, those are 38, almost $39,000. So clearly we know that there are some things that influence these numbers, such as the 5+ year claims may be more complicated, may be more difficult, have a higher severity, maybe wrongful death claims, whereas the ones that resolve under a year might not have such serious injuries. But when you look at those in the middle, it kind of shows you that every year that goes by, the payment is going to be increasing as a result. So this is important to keep in mind when we talk about things like early reporting, early claim resolution, and this really exemplifies why it is so important to report early to your carrier, your insurance company, so that they know that they might have something that they need to resolve. And the quicker it can be resolved, the better it's probably going to be for everybody. It's not going to be a protracted, prolonged litigation for the family members. They want to get these things resolved. They don't want this to drag on for years either. But also, it's easier to defend these cases when they haven't been going on for 5+ years, because the staff might still be available. Documentation can still be found. The longer these go on, sometimes the more challenging they can be to defend as well. So let's talk about some risk mitigation strategies. So falls. We've talked about falls forever, and they're still around and they're still frequent. So one of the things that we really want to focus on when we're talking about falls in the senior living community is just the importance of expectations management. And I can't tell you how important it is to really have those conversations with the families when they first come in, so that they understand that if their loved one was falling at home, chances are they're going to fall at the facility. You're going to do your best effort to keep them free of injury, but there's no magic potion that all of a sudden falls don't happen when you're inside the walls of a senior living facility. And we know that. And as challenging as those conversations are to have, it's very important that that's done. And when you have these conversations, it's so important to avoid terms such as fall prevention. Keep that out of your marketing materials. It's also important to keep the term fall prevention out of your staff training materials too. I can't tell you how many times I look at a fall program from a facility, and in their training content and in their slide deck they use, I see the term fall prevention used over and over and over. But then when we expect them to have these conversations with families, they're not supposed to use that term when we've trained them to use that term. So it's so important to take those terms like fall prevention, which we know is not a realistic goal, and take that out of all of your fall program and remove it from conversations, and really refer to things like fall risk mitigation, and we're going to try to reduce the risk of injuries, and have those terms when we're having these conversations. It's also important to be able to explain to the family what is meant by restraint free. So many times the family members do not understand why you just couldn't put full bed rails up for their mom, or you couldn't. I've seen one case where we had a case where they wanted, well, take a bed sheet and tie mom to the chair. That's what we did at home, and she never fell out of the chair. Why don't you just do that there at your place? And they get really angry that we don't do those restraints in a facility. So it's important to explain what is meant by a restraint-free facility, but also have it be a conversation, not just a one-time no, we're not going to put up rails, we don't do rails, and just move on, but really have those conversations with the families and allow them to ask questions. So why won't you use full rails for mom? Well, let me explain to you what the risks are of full bed rails and what can happen and what we know as experts who work in this field, and why the industry standards are to not use restraints in senior living facilities. And so that they understand it's not just your facility that doesn't want to do something, that that's the standard across the industry. So it's really important to have continued communication about why your facility is restraint free and what risk mitigation factors you have in place. Staff training and continuous education is so important. It really does show when an organization, a facility really implements a good fall program and they start to do training and they get the staff on board with it. But if you don't continue to remind staff and talk about fall risk mitigation and talk about interventions, that you see that they can have some improvement and then they continue, then they'll just backslide to where they were before. So certain things like teaching purposeful rounding and really reinforcing that constant reinforcement, reminders of staff, we're all going to do it. Even the administrative staff is going to round on residents, and really be sure that that's reinforced and you don't forget about it and kind of backslide as we have other important priorities, that we lose track of the fall risk mitigation strategies that we have. Fall huddles are another really important tool, and staff should know how to huddle after a fall and give document important information following a fall. We have some really good fall huddle resources that are mirrored after what are used in hospitals that we found to be really effective and can be really helpful in obtaining the important information following a fall, and hopefully to put some interventions in place to prevent another future fall. Event response is so critical. Be sure that all of your staff are trained in reporting falls. And one of the things about reporting falls is be sure that you have a definition of what is a fall in your organization. Because without that definition of a fall, people are going to apply the processes differently. Well, is it a fall if we assisted her to the floor? Is it a fall if she kind of rolled out of bed onto a mat? What's a fall? I can't tell you how many times I see that kind of ambiguity about what really is a fall. And if that hasn't been established at the onset, it's very difficult for staff to be consistently applying your post-fall processes and event response. Be sure that you're doing a root cause analysis of all of your falls, even the near misses. Really take a look at those and don't only just do the ones with injury, but really look at all of them, because the falls that might not have injury today might have an injury next week. So really apply those root cause analysis practices to all of your falls, including your near misses. Also, consider the use of technology in your fall program. Tony mentioned earlier Virtue Sense. They're one of our technology partners. They use LiDAR sensors in the room that use AI technology to detect when a resident is getting up out of bed, and can differentiate that between intentional movement to get out of bed versus normal movement, just moving around, repositioning in bed. And it can notify the staff and give them a heads up of seconds, minutes where they can get into the room. And it really helps if you have those residents that say get up in the middle of the night. You really don't want to have them at the nurse's station all night. But if you can get that notification that, hey, Mrs. Smith is up and she's on the move and she's starting to move around in bed like she's getting up, and give your staff that opportunity. And referencing back to one of my previous slides where we know the majority of falls are taking place unwitnessed. And so the room and resident rooms are where a lot of these falls are taking place. So think about using technology within your organization to help to mitigate those falls as well. Wounds, let's talk about wounds. So one thing that's really important in risk mitigation when we're talking about wounds is timely wound and skin assessments. We really want to see the wound skin assessments done within 2 to 4 hours from when they hit the doors to your facility and when they come in. Because even if a day goes by, or if they're admitted on a Friday, but the wound nurse doesn't come in until Monday, and this whole weekend goes by, it's very difficult then to go back and say, well, that was there when they came in, when in fact, you've got 2 days of them being in your building. And of course, they're going to claim that, their skin was perfectly intact when they came in the door. So the timeliness of these wound or skin assessments, even if it's not done by the wound nurse, is very, very critical. And we're always going to reference back to that when we have a wound claim. The first thing we're going to look at is what does that initial wound assessment or skin assessment look like, and when was it completed. It's also to ensure that you've got complete and accurate documentation of wounds. One of the things that we see frequently is that you might have one nurse that's really good about documenting everything about the wound, the drainage, the peri-wound, the staging. You've got somebody that's really doing a great wound assessment. And whereas other nurses, when they don't feel as competent with their or comfortable with their assessment, they might not feel like they can stage a wound or describe the exudate, or they're not really sure exactly what they should refer to something as, and so they leave it blank, and that's problematic. So be sure that your nurses are completing complete assessments, and if they're unsure, do some additional training so that they know how to properly assess a wound. Care planning is also critical. Be sure that your care plans are in line with what's in your treatment orders, and that they're not overly strict, and that they're not saying things that you're not going to be able to accomplish. That your goals are realistic in your care plan. To say that, well, the wound is going to heal by this date, and the wound doesn't heal, then it reflects poorly on the care. And in defense of that case, they're going to say, well, you thought it could heal in 2 months and it didn't. So how do you explain that? You use your expertise to believe that this was going to happen and you didn't reach your goals. And so it shows that you must not have done everything properly for that to occur. But it's also important to be sure that you're not putting in overly strict things into your treatments into your care plan, like to say we're going to turn them every 2 hours. Well, then the expectation is going to be that every 2 hours on the dot, there's going to be a turning of that resident, when it's much better to put in something realistic that they will be turned and repositioned throughout the shift, those types of things that are much more achievable. Wound photography is another thing to consider. I've worked on hundreds of wound cases in my career, and I cannot recall a single case where there wasn't at least one photograph of the wound. Either the family's taking a photo of the wound, the hospital has a photo of the wound, sometimes it might be OMI took a photo of the wound, but assume that a photo is going to exist. And to think that, well, if we just don't photograph the wound, then we won't have to defend against what it looks like, because chances are the photo is going to exist. And wound photography is very helpful because, for one thing, it really can show the wound when it's been cleaned. The wound looks good. It also shows proper measurements, so you can show that the wound is a certain size, versus if you just have a family photo, it's going to be blown up, 20 times larger than it is as an exhibit in a trial. So when you have the proper wound measurement, that can really be helpful too. Another thing that wound photography is useful for is in litigation. If we have good wound photos, a wound expert, a testifying expert, can use those photos to explain wound evolution and to explain how a wound or a skin abnormality that might initially just look like some purple coloring underneath skin might not look like much, but a wound expert can say, well, that's actually a dead muscle underneath the skin, and we know it's going to evolve to what it's going to evolve to. Whether or not pressure is relieved, whatever measures are done, you can't stop that train. You can't stop it from progressing to what it's going to be. So wound photographs can really be helpful to give that expert, that testifying expert, something to reference to explain to a jury. Instead of just having that very last picture, the worst picture of what it evolves to, they can kind of talk about how the damage is done, and then it's going to evolve to what it's going to do despite everybody's best efforts. I'd also like to encourage facilities to audit your wound documentation just to make sure it's consistent. Consistency within the documentation can be really problematic. You've got one person calling something a stage 2, somebody else is calling it a stage 4, somebody else is saying it's undetermined, and it really does get confusing, and it kind of takes away the credibility of all the staff that are caring for that resident. So do occasional wound documentation audits to make sure that everybody's calling things by the same thing. And if they're not, it's a great opportunity to go back and train your staff. So resident abuse. It's so important to do in-person abuse training upon initial hire. Don't just plop them down and put them in front of a video screen and have them watch a video about abuse, but really have a conversation with staff so that they understand what abuse is, that it's so important that they understand that the way that they speak to the residents, the way they treat the residents, it can be abusive, even if they don't might not see it that way. So it's important that they have an understanding, but in-person abuse training so that they understand how important it is to your organization is critical. When you have them do annual abuse training, consider having them sign an attestation that they did not observe abuse at your facility. This attestation can be very helpful in the event that years down the road there's a case in litigation and that disgruntled former employee is going to come back and say terrible things about your organization and how you abused residents or you neglected residents. But if you have them sign annual attestations that they did not observe abuse, now this is given that they did not observe abuse and didn't report abuse, but they can assign that attestation and keep that in their HR file, that can go a long way to refute any future statements they might make about abuse at the facility. Be sure that you have processes for responding to abuse allegations, including removing all accused staff members from direct resident care until the investigation is complete. And that means it doesn't matter if you're short staffed to say, well, we just moved them somewhere else, or we have them not didn't have them take care of those certain residents. It really reflects poorly on the organization when staff are allowed to continue to provide resident care when there's been a complaint of abuse. Be sure that you have a robust screening process for all staff with background checks completed prior to any resident care. And again, you would think that this is done all the time. I can tell you it gets missed because some facilities are so desperate to get them up and running and out on the floor that they might have done the processes for submitting for a background check but might not have the results back yet. And they'll put them out in providing resident care. But be sure that you get your background checks and all this proper screening has been done before you ever allow a staff person to provide any resident care. Elopement drills, elopement prevention. And this is one term that I do believe we should say elopement prevention because it's one of those things that elopements should not take place. I can't stress enough the importance of elopement drills. It is interesting that so many facilities are great about doing their fire drills, not so much elopement drills. And when I tell them, they're much more likely to have an elopement than to have a fire, but the elopement drills oftentimes can get missed and not prioritized. It's important to do full elopement drills on every shift at least twice a year. It's also, but also when these are done, when the elopement drills are done, be sure to really look at the data and have a process for going back to the safety, the risk, the quality committees so they can evaluate the elopement drills and identify any areas for improvement because chances are in every one of these drills there's going to be an area for improvement. So don't just do it as a process, well, we just go through the motions and we do the drills. They really do them with the intent of we're going to take these drills and we're going to look at them for identification of areas of improvement. Elopement risk assessments. Be sure that these are done and there's a process in place for doing elopement risk assessments, especially in the assisted living and memory care facilities. Do environmental assessments when it comes to elopement risk. I cannot stress this enough. I go to facilities all over the country and often, many times, I'm going to say often, but many times I see facilities that they might have a WanderGuard system. They check the WanderGuard system. They're doing great with the WanderGuard system. But then they've got some areas of vulnerability when the windows might open completely wide enough that anybody could jump out of them or jump in. They've got back doors or kitchen doors that aren't secured and the door to the kitchen isn't secured. So really, every once in a while, do an environmental assessments to look for any of those areas of vulnerability where people are propping doors open, because you'll find it. I would say probably 50% of the time, I find some area of vulnerability when I do an environmental assessment of a facility with a WanderGuard. The other thing is to have an elopement binder with photographs of residents known to be at risk for elopement. I know we all have, so many facilities have electronic records, they have the photographs in there, but if any of you watch The Pit, you know that these electronic systems can go down. We can have cyber attacks. We can have a lot of things. So have a printed photo of those residents at risk that and have it in an elopement binder. Don't just think that you're going to be able to pull up all of that information on the resident if an elopement happens, because you might not have access to your records. Anything could happen. So be sure to have an elopement binder, like we always have in the olden days. And track and trend your elopement near misses. I hear facilities say sometimes, well, they just made it out to the parking lot. Well, did you track that as a near miss? Did you investigate that? Well, it wasn't a true elopement. They only made it out here. Well, whether or not they consider that elopement is another story, but it's really important to look at anything that you consider to be a near miss of an elopement and really look to how that can be fixed and fix it before it becomes an actual elopement. And track and trend. And be sure to encourage your staff that it's more important to report it so you can address it than to say, oh, great, we were elopement free this year. It's much more important to look at any of those times that you almost missed something and didn't. And then establish an escalation grid for missing residents so staff know when to contact and who to contact and all of those things. Medication errors. So it's so important to complete a medication administration competency check prior to allowing staff to administer medications. This competence should be written and practical. So observe them doing a med pass, at least one. And be sure the agency staff is included on this too. Never assume that agency staff is competent in medication administration, and you need to have a system in place for verifying that before they do their first med pass. Retain these competency checks in HR files. Don't just keep them in education files that might be thrown out when the employee resigns or after a few years. Be sure that any competency checks remain in their permanent HR files. And complete random QA audits and observation of MedPass. This is really important to just randomly go through and watch, because people kind of backslide a little bit and don't always follow the proper processes. When they're familiar with the residents, they're familiar with the medications. They might not always be following all the proper steps of medication administration. It's also important to have higher acuity indicators in assisted living. So we know that one of the big severity types of claims in assisted living is failure to transfer to a higher level of care when warranted. So it's important to have these standards for when a resident should be transferred out to a higher level of care. And I understand that this is difficult. Oftentimes the families do not want them transferred to a higher level of care. It's more expensive for them to go to a higher level of care, but it's really taking on a big liability if you don't have processes for sending them to a higher level of care. So what are some of the indicators? Increased wandering, failure to comply with service plans, increased falls, increased dependence with ADLs, when skin issues, unstable or chronic diseases. Just by requiring more medication changes, lab work, that might require them to go to a higher level of care, and also increased behaviors, aggression, noncompliance. So here's the question for you. What percentage of long-term care claims settle with indemnity? Is it 90, 80, 50, 30%? So put in your guesses. The actual number is 80%. So 80% of the time you receive a lawsuit in a claim or a claim, it's going to settle 80% of the time. So that's why it's really important to get on the ball and start acting in these cases and getting prepared and saving records and those types of things, because 80% of the time these are going to pay out in some type of indemnity payment. So with that, we will open it up for questions. And while we're looking at, or you're submitting questions, you can log in and get your CE certificate. We've got this fancy QR code here right now. You can scan it with your phone. It'll take you to the website, and you just need to put in the password, which is CareAgents26 with a capital C and a capital A. Or you can go to this link here at the top and then enter the password. So with that, as you're downloading your CE certificate, we will open it up for questions. And I think Tony is monitoring for questions to see if you have any.
Excuse me. Looks like we have a question. I'm just going to read directly here. As a renal solutions provider contracted inside of SNFs, one of the most significant loss drivers is the reconciliation gap between the contractor's clinical documentation and the facility's MDS and nursing notes, particularly around intradialectic events, hemodynamic changes, and post-treatment assessments. Is CareAgent seeing that dual charting liability gap drives claims, and how are we advising facilities to contractually close it? So that
That's it. Yeah,
take a moment
that's
to think about that, but
yeah, yeah, that's a great question. Um, and we see it not only just with dialysis, but also with wound providers as well. They're coming in, they're doing their own documentation, and is in alignment. Now, uh, let me answer your question in two ways. Is the first, does it lead to more claims, greater liability? Well, it does in the sense that if there are things that are not being properly communicated, if there are things that they should know in the medical records, so that's where inconsistencies in medication and medical records are problematic. If it's something critical that should be communicated to staff that's not found in the record, that can actually lead to a claim. That doesn't happen often in this type of setting. It's much more common to see that in more of the higher acuity settings like the hospital. So if somebody's didn't properly document something, or it's not consistent with what somebody else is seeing, that can actually lead to misunderstandings, that can lead to patient resident harm. But the issue with that those discrepancies in senior living cases is in defense of these cases. When somebody is saying one thing and somebody is saying something else, it really makes it difficult to decide, well, who do you believe? Which is the true story here? Were they having this problem? Were they not having this problem? Why wasn't everybody aware of it? And it makes it difficult to defend those cases, to show that, yeah, we really knew what we were doing. We were competent. We were providing great care. But when you've got these doc, different pieces of documentation that aren't in alignment, it's very difficult to defend those cases. And also when it goes to an expert to say, okay, expert, look at this documentation and tell us whether or not they met standard of care. And the expert goes, well, I don't know, because this person's saying one thing, and then we've got somebody else over here saying something else. So it's difficult to say if they really met standard of care, because you really can't tell sometimes what the true situation was and what the actual truth of the situation. Does that, tell me if that answers your question or not?
I believe it looks like so far it did. That was it's a very loaded question with
It
probably a
is.
lot of answers, but and yes, thank you. We did have another question come in. Are you able to send a sample of the annual abuse attestation?
Yes, if you, okay, so I hope everybody's had a chance to scan the QR code. I'm gonna advance here. This is our references, by the way. So if, like I said, if you do want to know some specific, where was this found? So if you want to be able to take a statistic back to your organization, this is where all the data is found. But here's my email address right here. If you want to shoot me an email, or put your email address into the chat with that request, we can certainly provide that to you, or a sample, just to, kind of some ideas of what that would look like.
That's a great. Thank you, Monica. That would be great. We did have, looks like another question come in. Um, Going back to kind of it looks like the beginning topic, but why do you think assisted living claims have a higher severity? I think you touched on a couple areas earlier, but please, if you have anything else to add.
That's a great question. And I was actually talking to an assisted living owner not long ago, and I shared that statistic with them, and he said, why? Why do you think assisted living claims are paying out higher than skilled? Um, I think there's a multitude of reasons. I touched briefly on the staffing issues that I think assisted living clearly there's been some research to show that the staffing issues are having an impact in being able to identify residents that are needing a higher level of care. But there are a couple of other things that I've heard from claims people as far as defending assisted living claims. One of the complaints I hear is that there just isn't a lot of documentation. Um, and where is the documentation? And they don't always realize that documentation standards are different in assisted than it is for skilled. So we're not going to see as many assessments. We're going to see more of an evaluation of things, and it may not be written by a licensed provider. It might be from other staff that don't have as much training on how to do documentation. So there just isn't as much documentation that can be relied upon to defend the case. And another thing that I see in assisted living facilities that I think make it difficult to defend them is a lack of policies and procedures. There aren't the requirements to have them like there are in skilled facilities. And sometimes they can be more of an operations manual. They might follow more of a social model. But when those policies and procedures really haven't been established to look at things like how do we define a fall? What do we do after a fall occurs? And have those established in your policy so that you can reference those and say, we apply this consistently and this is what we do. It can be very difficult when there just isn't a lot of documentation that can be used to defend these cases.
Yeah, thank you. Um, Monica, can you go back and think about the part where you were kind of talking about the medication administration competencies? And someone's asking a bit about, would you recommend that somebody still should have a competency upon hire, even if they're supervised throughout their shift by, a licensed nurse, for example, that already went through a competency?
That's a great question, and the answer is absolutely, absolutely. You really need to. You should never assume that because somebody has any type of a license that they're competent to do any type of activity, and not just medication administration, but things like Hoyer lifts. We see a lot of Hoyer lift claims, and some organizations will assume that well they have their CNA, so clearly they're competent at using a Hoyer lift. Well, they might have used a different Hoyer lift than you have, um, or they might have learned wrong technique. You can't, you still have that obligation to be sure that the people that you are putting in a position of caring for those residents are deemed competent. And so with medication administration, it might be, say, giving meds through a G tube or something like that. And you might have a nurse that hasn't done that in a million years. I haven't done it in a million years. Um, so it's really important to watch the way that they give medications, but also they might not be following all the proper steps to administer medications, which we know it's the five rights, the right patient, the right time, the right medication, the right, all of those things. Do they really follow those, or have we kind of let our practice slide over the years? We might have a lot of years of nursing under our belt or medication administration under our belt, but we might have kind of backslid in our proper technique for how we administer things. So it's important to have a process for documenting that, yes, they were observed to do these things. They were observed by somebody that was in a position where they had been deemed competent themselves, like a nursing leader um, individual, and like you said, somebody that's been already deemed competent themselves. Um, and to have it on a competency check sheet or have it somewhere and have that information retained. So in the event that somebody does make a medication error, say they were supposed to get 20 milligrams of something and they got 40 milligrams of something because somebody made a math error, when you can show that, well, we deemed her to be competent, she knew how to do it, it was an error, versus to look at the organization as a whole. And whereas your liability, when you don't even make sure that they actually have ever known how to do this, and maybe they were making this mistake all along and they just didn't know what you were doing, they were doing, but you never bothered to check and verify their skills.
Yeah, thank you for answering that. Makes a lot of sense, I believe. Um, Someone else asked, kind of going back to, it looks like when you were talking about choking. So what can be done to, and again, you may have answered a little bit of this before, but can you expand on how to reduce the risk of choking claims? What can we focus on in senior living?
That's a great question. It's really easy to audit the trays to make sure that what's being ordered is in compliance with what's being given, and have processes to make that into a QA project to be sure that especially those residents that are on specific diets and have been deemed to be at risk at choking are getting the proper diets, and it's being done consistently. That's where I see it fall through the cracks. And when we've had claims, they've been supposed to be on one specific type of diet, they didn't get that diet. We had one with they were supposed to be on chopped meats, and they ended up choking. They had some type of a Salisbury steak kind of thing for dinner. They choked, they died. Well, on autopsy, they were able to get the piece of meat and to show that clearly it did not, it was a big chunk of meat that hadn't been cut properly. So clearly the diet orders had not been followed. So audit that. I was at a facility not long ago doing a risk assessment, and I saw a resident get the wrong tray, and the meats weren't chopped like they were supposed to be, and she knew enough to ask somebody, and somebody came in and chopped the meats, and that's a near miss. That's absolutely a near miss when that happens. So it's really important to stress to everybody how important it is to follow dietary restrictions, because if you have a choking claim, it's usually because somebody made a mistake in the dietary department.
Yeah, that's unfortunate, but we know we've seen it. But thank you for the explanation. Looks like we have one other question, which is a bit more general here. What do you think can be done to reduce the severity of assisted living claims?
That's a great question. I wish I had the perfect answer for that. But I do think that one of the big drivers is knowing when to have those conversations that they're no longer appropriate for assisted living, and be sure to have processes for transferring them to a higher level of care. I think that's probably when that's in place, I think that that is going to eliminate a lot of those claims, because what happens in some cases is they're going to portray these assisted living facilities like, well, they just didn't want to lose any resident revenue. So it was because they wanted the revenue that they weren't willing to transfer them to the appropriate level of care. And that sounds really bad when usually the facilities are doing everything they can to let the resident age in place, and they really have the best of intentions. But it's really going to be used. The story is going to change, and they're going to say that you weren't transferring them because you wanted them to be continuing to pay rent. So those are the things to keep in mind, to be sure that you really have processes for sending them to a higher level of care and documenting those conversations as well.
And it sounds like that probably goes right into kind of expectation management and talking to families up front about, changes in care as time goes on and what that might look like and to ease the those conversations later. So,
Yeah, absolutely.
okay, we have one more question. Um, would you advise that skilled nursing facility employees be aware of basic safety check documentations that are performed by B2B contracted dialysis provider? So as the SNF is ultimately responsible for those actions, would it be a good idea to have an employee at least know where to locate those logs in case a contractor would not be on site that day or have basic knowledge of water safety, for example, specific to this person's environment, I'm sure, but
Mm-hmm.
maybe you have some thoughts there, Monica.
I don't know. What do you think? So Tony, as a former nursing home administrator, she's a licensed nursing home administrator. What do you think about that? Because I really don't. Yeah, that's it is difficult when medical information is siloed, and I think that's kind of what you're talking about, when different types of medical information live in different silos and it's not shared, because there are different platforms and that kind of thing. That can be very concerning. So that is definitely something to have a discussion with the facility to talk about how access can be shared amongst different platforms. If the dialysis information lives in a specific platform that the facility might not have access to, and it doesn't speak to each other, what are some safeguards and kind of some safety nets that can put in place so that at least the critical information can be accessed? That's a great point. But yeah, I've never dealt with that one, so I'm not as familiar with that. Tony, do you have any thoughts about that one?
Yeah, I'll just say a quick note about that is really, I think any sort of medical information, as a skilled nursing provider or an assisted living provider, you're ultimately responsible for that person's kind of overall well-being, certainly. So even if something is being done by another provider, their overall care ends up being your, responsibility. So I think, the communication is key. Um, in my own experience, when we had an on-site dialysis provider, although it was a third party, we did share the same space. It was difficult from time to time to receive ongoing communication. So we really created a solid communication plan, met with the leadership to figure out how shift to shift, how are we going to communicate the status, the changes of the residents. And then from an environmental perspective, just, caring, using the same space, make sure that we had supervisors that had access to the dialysis area and access to those other, clinical areas in the building to have that kind of shared space and shared responsibility. So hopefully that answers your question, Jason. We might not be touching on it exactly, but sharing some of our thoughts here. But if we did not get to any of your questions, we will follow up with you via email or phone. You see Monica's emails here. I'll take note of any requests that came in for additional information. But we really appreciate everybody tuning in. As you know, we put on some webinars regularly, so please feel free to chime in when you see the survey questions pop up. We like to gauge everybody's interest on topics that we want to kind of discuss next. So, Monica, anything else?
Nope, I think that's it. I think when I end my slideshow, they get access to the questions, I hope. So, but yeah, thank you all for joining. I actually enjoy learning all these statistics, and I hope you do as well. So, thank you for joining us.
Thanks, everybody. Have a great day.